Okay. Good morning, class. Kumusta?
Okay lang po, Doc.
So can you see my slides now? First slide.
Yes po, Doc, sa title page po ng presentation.
Okay. So we already have a lot of time to read, no? Kasi wala tayong lecture last week and then holiday pa yesterday. So mataas-taas yung time nyo na basahin yung lectures and topics natin for today's quiz. So I'm expecting na maka-answer kayo sa quiz later because my the first part for today's lecture is a jump off case of what we will be discussing more on the clinical aspect of the musculoskeletal pain and spasm. And of course, to understand this, is kailangan natin ng background dun sa skeletal and smooth muscle physiology, which you already read no from last week pa. And then for the past 2 weeks, no, binasa nyo na tong lecture na to. So I hope you can answer the quiz later on. So the outline of my talk for this morning, naghang, no? Wait lang. Okay. So first, we have a case scenario, and then we will discuss the musculoskeletal history and physical examination, approach to MSK pain, and we discuss the pharmacological and non-pharmacological intervention for MSK pain. So, itong topic na to is medyo advanced lang siya because we are incorporating the basics as well as the clinical and the pharmacologic na intervention. So this is not just purely physiology, but meron na siyang mga clinical integration with regards to our topic. So yan yung importante rin malaman natin that when we read, we have to know first the basics and then apply that to a clinical scenario so that we can see the whole picture, especially when we're handling patients with musculoskeletal pain and spasm. So for our first case, we will have a jump off case. So sa medicine, we first year, of course, basic, no? Basic subject, foundational subject, like the physio, anatomy, biochem. And then when we go to the second year, meron ng konting clinical, like sa pharmacology, and then physical diagnosis. Then when you go to third year, already purely clinical na siya, no? Like internal medicine, pediatrics. But yung mga subjects natin during the starting from second year, third year, fourth year, may halong clinical na yan siya, no? But as early as first year, we introduce you na to the clinical aspect and clinical application. That's why when you read your physiology, meron yung section or parang heading no na mga clinical applications. So maganda yan siya para makuha nyo yung totality of the lecture, kung ano yung mga how will you apply that to your patient because ang goal natin is to become a physician and to treat the patient suffering from different medical conditions. So isa na tong this lecture is yung sinabi ko nga jump off case in our understanding of skeletal and smooth muscle physiology. So let's move on to our first case, a 35-year-old female office worker. So imagine yourselves as the one kayo na mismo no, kayo na mismo mag-manage, you being the doctor already, and then you are in the hospital, you are in the clinic, you are in the community. So kayo na mismo yung pinupuntahan ng patient for a complaint of, meron tayong three cases for today. So yung first case is a 35-year-old female office worker, presents with a 2-day history of acute neck stiffness, restricted range of motion, ROM, and aching pain are relating to the shoulders. Okay? And then symptoms worsen after long hours on a laptop and using a smartphone. So what do you think is the patient's profile describing na ano ba yung profile niya, no? Ano ba yung, paano niyo siya ma-picture out yung patient na to? So most likely, how will you analyze the case of this patient? So isa siyang corporate, no? Nasa corporate world, most likely office lady or virtual assistant, no? And then we have the patient number two, a 42-year-old female housewife. So she cooks daily, cleans the house, wash all the laundry, and goes to the market. While lifting the sofa because nga housewife impatient, she felt a sudden tightening in her right shoulder, followed by immediate sharp pain in the upper back region and shoulder blade area. Then a third case, last case, 28-year-old female nurse, sudden onset of severe cramping pain in the right lower back lumbar region that began 24 hours ago after lifting an ICU stroke patient. So meron tayong isang patient na nurse, and then when lifting an obese or an overweight patient sa ward, nagkaroon siya ng sharp stabbing and involuntary muscle contraction or spasms in right paraspinal muscles. So how will you, if kayo yung doctor for these patients, how will you approach, no? So yan yung number one natin na question in our mind. How will we approach this kind of patients complaining of pain and muscle spasm? So our first case, meron tayong office lady. And number second, housewife. And our third is an ICU nurse. So from the International Association for the Study of Pain, so this is a group of medical doctors and researchers, and yung goal na lang talaga nila is to study about pain, no? So yung objective nila is to have more understanding on the pain. So this was established since 1974 and until present, and 50 years around 2024. So when we describe or they define what is pain, it is an unpleasant sensory and emotional experience associated with or resembling that with actual or potential tissue damage. So ano yung, how can you understand the definition of pain? Based on this statement, ano yung reflections nyo on the definition of pain? Sige, basahin niyo ulit and tell me, no, kung ano yung mga uh, picture out nyo or ma-react nyo about sa definition of pain per se. About Mosot Ayman Zail.
Um, Good morning po, Doc.
Good morning.
So, um, coming from the definition of pain as provided by ASP, I would say that uh, pain can come as a subjective experience. For example, since all of us have different tolerance good with pain, Doc, and it comes off to different causes, like for example kani as mentioned, sensory and emotional experiences that then would cause bodily sensations and emotional reactions that drive to pain rather than physical pain or reflex po, no?
Okay, no? So that's correct, no? So you use the word subjective. So when we describe pain, it's always a subjective response or a subjective complaint, no? We cannot tell na, like for example, na isa ka patient, then you ask them na, ma'am, kumusta? Or ano yung naramdaman mo today? Saan yung masakit? So when you ask them, and then the patient would say, Dok, sakit yung kayo, Dok. Likod na ako, sakit yung kayo. Murag di na ako makalingkod or makatindog sa kasakit. And as a doctor, you dili nimo siya kontraho, no? You cannot say na sure jud gamam na sakit imong likod. So that's an irrelevant na statements, no? Pag when you are entertaining a patient na with painful sensation, because nga the pain is subjective. Kung ano yung naramdaman ng patient, you have to record and take note of that, no? Kung sinabi niyang 10 over 10 sa kasakit, you must accept it na 10 over 10 talaga sa kasakit because that is a subjective sensation or feeling of that patient. And yung other key terms dito is sensory and emotional because it leads to the decreased quality of life, no? For so patient with pain, We expect them to hindi na maka-work, hindi na makapunta sa school, makapunta sa office. Take, for example, if you have a toothache, di ba? So pag may toothache ka, sakit ka ayo, di na ka study tarong. Di na ka makaadto og school or di na ka makalihok sa kahit simple na household chores, no? Kasi nga masakit yung ngipin mo associated with or resembling that with actual or potential tissue damage. Actual meaning merong inflammation. So when you are already in a second year, you will have a lecture on the inflammatory process, di ba, sa general pathology or potential tissue damage if ever there is no actual evidence of inflammation yet, but pwede na siyang magkaroon ng pain pa rin because of the potential tissue damage. So definitely these three patients are complaining of pain and then neck pain, shoulder pain, and the low back pain. When pag meron na kayong clinic or in the clinical history taking, you will ask the patient about the subjective, di ba? Subjective complaint of their pain. So you ask them in a scale of 0 to 10, ma'am. 0 ang walay sakit, 10 ang worst possible pain. Unsa ang imong mahatag na number or can you give me a number in regards to the severity of your pain? So yan, pwede mo siyang tanungin yan kung 0, 1, 2, 3, 4, 5, 6, 7, 9, 10. So, yun lang yung range, hindi naman siya malampas na to 11 to so on. And then we have the Wong-Baker Faces Pain Rating Scale. Original developed for patients with cancer pain, but pwede natin itong i-adapt as to scale them, no? But in terms of the pain scale from 0 to 4, 6, 8, 10. So we can use this when we interview the patients and we can record their severity of pain. And now, so meron tayong patient with pain, and then we ask them on the severity of the pain. And now we go to the history taking in rheumatology. So for this part, it's already in the physical diagnosis. Okay. So remember that we are approaching this patient or giving you like this lecture in holistic approach. So we incorporate na yung different mga subject matter that you will be discussing in the medicine. No? So history taking is during your second year when you ask about the onset and duration, kano sa ang sugod, ang pain, kano sa ang sugod ang sakit sa likod, ma'am, no? Kano sa man nag-atake ang pain, o unsa na adlaw, unsa na kano sa na bulan, no? Pila ka adlaw na ni siya nagsugod, unsa kadugay. MSK area of concern, asa man banda ma'am masakit? Sa likod, sa atubangan, sa kilid, sa ilalom, presence of inflammation. So ano yung mga cardinal signs of inflammation? We have the redness, swelling, the tumor, heat, no, and warm, as well as the yung mga discoloration, no, or mga hyperpigmentation. Number of joints affected, kung ilang joints yung affected. So we have, I will show you later yung image ko ano yung mga joints na kailangan natin i-take down na affected joints and aggravating or living factors. So ano yung makapagrabe sa pain? So for kung mag-alsa siya og sofa yung IC nurse, so musamot siya pag magkarga og pasyente or when the patient have pag makarelax, makalingkod, ma-relieve yung pain niya sa likod. Symptoms outside of the MSK complaint. So associated signs and symptoms aside from the back pain, the neck pain, and the shoulder pain, and previous and ongoing treatment and responses. So if the patients have ongoing treatment, so malaman din natin kung ano yung mga underlying problem niya aside from the pain itself and the patient's level of function. If the patient can work pa rin without activity, without assistance, no? Kung, or with assisted devices. So this is a homunculus model of patients na we will assess them mga different possible joints that can be swollen. So meron tayong this image, we can use this in our clinic. So meron 44 joints that we can use. So different parts of the body. So try to look at the image. Doon sa face, merong at least tatlo. Then sa shoulder, sa may thorax na merong apat. Then in the both upper and lower extremities, including the hips, the knees, and the ankles. Pati na yung mga joints sa ating hands and feet. Okay. So kung i complain ng patients kung asan banda yung masakit, ituro niya. For example, for the patients with neck pain. So kung ituro niya dito sa may left banda, so you have to cross that out. Then kung sa my shoulder, kung dito banda sa my deltoid, you have to cross that out or check or shade, no? So that you can know what areas are affected. And then also you can use this to prognosticate the patient, especially during follow-up, kung nag-improve ang patient or wala during your treatment. And then after documenting the areas of pain, we will have this assess no the sensory cut or if there is involvement of the dermatoma level already. So I don't know if tapos na kayo sa nervous system na discussion sa anatomy. Saan na ba kayo banda ngayon sa anatomy?
Kaka-upper limb lang po, Doc.
Upper limb. So included na doon ang mga nerve involvement, di ba? No? Innervations of the upper limb.
So far, Doc, is sa muscles pa po kami nag-focus, Doc.
Muscles pa, okay. So
Opo.
medyo advanced lang tayo yung lecture ngayon kasi when you will be discussing about the upper extremity, so meron tayong tinatawag na dermatoma level. So medyo advanced na ng konti. So kung meron tayong pain dito sa may deltoid area, for example dito banda, so this is my I'm tapping my right deltoid area so that kung merong tingling or numb sensation here, so that is the level of the C5 already, no? So cervical 5. So try to trace the roots of your cervical nerve dito sa may neck area. So remember that we have 7 cervical spinal vertebra. So yung if ever may numbness dito, then we will trace that. Most likely yung level of involvement of the spinal nerve is nasa C5 or cervical 5. And dito sa T4, so yung sa breast level, T4 yan siya, no? So kung merong patients complaining of tingling or numb sensation sa my breast area, it's already at the thoracic level, no? T4 level because we have T1 to T12 na thoracic na spinal involvement dito banda. So yung landmark natin is yung T4 sa breast, T10 sa may umbilical area, and then T12 na sa may hypogastric area. And then, yung sa hands, no? So, sa may thumb and sa may pointer, nasa C6, C7 yung sa may middle, then C8 yung sa fifth finger. Then sa lower extremities, yung sa may groin and hip perineal area, lumbar. Because we have L1 to L5, lumbar spinal nerve. Then yung mga dermatoma level is doon sa thigh, L3, L2, L3. Then sa lower leg, L4, L5. L5 if nasa lateral, L4 pag nasa medial. And then yung sacrum. Since we have diffuse or we have fused pala no, sacral vertebra. So S1, S2, S3, S4, S5 din yan siya. So kung meron tayong tingling or numbness we feel on the medial aspect of our ankle, nasa S1 yan siya, as well as the lateral aspects of our feet. And pag medial aspect of our feet, nasa lumbar 5. So we have laid the history taking of the chief complaint. We characterize the pain, yung ito ng mga aspects, and then we assess the swollen joint and as well as the sensory dermatoma level. Then we will proceed with the review of system. So review of system, which means that we have to check the different organ system, no? Other than the muscle pain. So aside from the muscle pain, which these three patients are complaining, they are complaining already of the back, the neck pain, shoulder, and back pain. So ano pa yung other symptoms that they are feeling aside from those chief complaints nila? So we asked for meron bang fever, ikalintura ba ka ma'am, nag-weight loss ka, nagwalaan ka timbang, na ba kay gana magkaon or luya permente. You will check for the skin, no? So naabay mga pula-pula ma'am, naabay mga changes sa nails, nangatanggal ba yung buhok, sa head, ears, eyes, neck, and throat, naga-blurring ba yung vision, yung mata, na ba kay mga luas, uga ba yung tutunlan, na ba yung mga bukol-bukol. Sa chest, nagasakit ba yung dughan, no? Nagapalpit, nagapaspas ba yung beat sa imong kasing-kasing, lisod ba maginhawa, hangak ba man pag maglakaw, maglisod ba ka og higda pag maglisod ba ka ginhapon nakahigda. And then for the gastrointestinal, sakit din mong tiyan, nagasuka, nagakalibanga, naga-constipate or maglisod og libang, mura ba og tae sa kanding imong tae na ay dugo, pula or murag uling. So that's how you will ask the patients no in our local dialect. Sa genitourinary, nabay dugo imong ihi, mura bag bula imong ihi, ginagmay lang ba imong ihi, nabay bato pag mangihi, sakit ba mangihi o nagapangihi ba kapag gabi. Then extremities, nagahupong ba imong tiil, naga-numb imong tiil or kanang hawoy imong tiil, sakit gihapon ba imong mga muscle or nagalahi ang color sa imong mga toes pag ma-expose sa bugnaw no because of we are thinking about Raynaud's phenomenon. And then the CNS paralysis to medyo advanced naman ito ng mga symptoms like di nakakalihok, half sa imong body dili na malihok, sensitive ba ka sa pain kung gamay lang na matarog lang gamay imong skin, sakit na kayo, nagasalimuang ba ka sungod sa kasakit or mukalit lang ba o lihok imong kamot masingula nimo gituyo. Okay? So from the review of system, we will now proceed with the other components of history. Like we ask them for the past medical, kung ano yung mga nahitabo sa una, no? Especially sa mga past medical history of the patient like na ba kay mga problema dati sa kasing-kasing, unsa ba ang mga sakit nimo sa una, unsa ba ang mga sakit nimo katong na-admit ka ani na panahon na nahatagad ba ka og mga tambal na ginainom nimo na operahan ba ka sa una ug na ba kay mga reaction sa mga tambal. And then sa family history, important din ito because you have to know mga heredofamilial diseases like nabay nagasakit po sa inyong family ma'am sa una, nagasakit ang likod, nabay mga sakit na arthritis, lupus, or mga infection ng mga pamilya, TB ba? High blood, diabetes, included na yan siya, na common siya ng mga heredofamilial diseases. And then personal social, nagasigarilyo ba ka ma'am, sir? Nagainom og alak, nagagamit kag bawal na droga. And then sexual history of especially among common no, among men and women. So you ask them kung anong, especially pag adult na or mga reproductive age group, like unsa we have what we call as the coitar, anong age mo first nagkaroon ng sexual intercourse. And then we have the menarche, kung anong age na nagregla. And then um, tawag nito, ilan yung sexual partner niya. In short, how many times na siya nagkaroon ng sexual intercourse. And then sa OB, kung ilan na siyang beses nanganak, nabuntis, na abortion. So we have OB-GYN scoring, pregnancy morbidity, kung ikapila siya nakuhaan, LMP kung saan siya uh, first day of yung last menstrual period niya, and then age of menopause. Kung saan siya nag-stop na ayang regla. And then after asking for the pertinent history and then the review of system, so we will proceed with the physical examination. Okay. So when we ask the patient uh, for the particular patient number one, so look at the affected area. So ano yung pain niya doon sa kanya is yung sa kanyang neck, no? So look at the neck, check for the symmetry, trauma, deformity, bruising or swelling. Check for the presence of inflammation, redness or sinus. Then malignancy, kung meron mang bony or soft tissue mass without history of trauma. Then let them point, ask them to point kung saan yung part na affected, no? Anatomical site of pain, dermatomal distribution, if any, no? Like yung sa dermatoma level na pinakita ko kanina. And then ask them to move. So ask them to look. First, you have to look muna, inspect, then try to point, ask the patient to point kung saan banda. Dili banda, dok. Okay, then try to ask them to iliyok daw, ma'am, no? So try to ask them to move if there is pain during movement or joint-specific tests. So like for the first patient, so you have the cervical spine neck region assessment, look and observe any abnormal curvature. So we have to ask the meron bang anyone from the group na physical therapy yung ano nila undergraduate course?
Parang wala
Parang
po
wala
sa
po.
amin
Wala, no?
yung batch
Sige
doc,
lang.
yes po.
So, if, kasi pag physical therapy na mga patient, mga students, medyo advanced na yun, or medyo may background na sila for this, no? So, for our first patient, always go back to our patient na when we are discussing this, like this PowerPoint lecture. So, yung kanina history taking, so applicable to all three patients. And now, yeah, we'll go to the first patient na because of the complaining of the neck pain. So for the first patient, to assess physically the cervical area, look and observe any abnormal curvature, so cervical extension and flexion, point to any site of discomfort, and move the specific area. So cervical rotation to the left and to the right, and then lateral tilt to the left and to the right. So kung meron kayong na-observe na pain, so i-note na dyan, no? Note kung saan banda kung may masakit. For the second patient complaining of shoulder pain, you have to look for asymmetry, then let them point to the site of discomfort, and then ask them to move the specific area. So we have the modified scarf test to check for the acromioclavicular joint pathology here. Uh, So, yan na. So let the patient hold dito and then apply uh some force, no, by pushing your elbow towards your shoulder. Yan, no? So kung pag sakit, so there is an acromioclavicular joint pathology. And then let them perform the both left and right. So vertical position and then horizontal, no? So if there's pain on the part na shaded dito banda, so this definitely ACJ or acromioclavicular joint pathology already. And then this is what we call as a robot position. So neutral shoulder like this one. Sana, klaro. And then neutral shoulder, external shoulder rotation pag towards the the line, no? Towards away from the center line, and then internal shoulder rotation if going toward. So kung merong pain, like for our second patient, kung may pain maramdaman, then of course we expect inflammation, no, sa shoulder area or sa tendon. And then for our third patient, so how will we perform the physical examination? So for our third patient complaining of low back pain, although that patient is a female, we don't really need them na maghubad ng damit, no? So this is for just demonstration, but we can let them also stand sa clinic or sa hospital, but we can look from the back if there is deformity, or you can palpate naman sa likod, no? Kung meron bang um, mga deformity sa likod, you can palpate also sa spine kung hiwi ba yung likod or dili. And then let them stand. And then spinal flexion, instruct them to touch or to grab the floor using their fingers. And then spinal extension, tayo sila again to the spine neutral position. And then let them or instruct them to look at the ceiling. So expect patients na mayroong mga cervical nerve impingement pag mayroong pain on different maneuvers. So spinal flexion and spinal extension. Now, to further assess, no, kung meron bang pain or yung tinatawag natin ng mga sciatica. Okay? Di ba, commonly we observe or we hear that term sciatica. So we have the SLR or straight leg raise test with neck flexion, and then the slump SLR with neck extension. So parang nakaslouch yung patient ba, nakaupo, no? And then yung affected na area, left or right, and then yung foot upwards, and then yung neck nakababa. Okay? So merong, if there's pain elicited on this motion, sa first na picture, there is impingement of the sciatic nerve, no? Or meron sciatica. If patient na i-raise niya ang head niya upwards, ma-relieve yung pain. So definitely may possible sciatica in patient. And then in the next picture, yung neutral position, nakatayo lang, hands on the waist, and then try to ask them to reach the popliteal area. And then if ever may pain on side bending and rotation, so meron ding affected na possible nerve impingement here, sa na-shaded area. Okay, after hearing the history and performing the physical examination, let's now let's now try to dig into our differential diagnosis, okay? Especially when how to approach these patients complaining of MSK pain, because all of them are complaining of musculoskeletal pain in the neck, shoulder, and back. So now, paano natin siya ma-narrow down to our diagnosis, because we are entertaining a lot of medical conditions, and then we are also thinking of other possibilities ng mga etiologies of their pain. So this is a guide from Harrison. So when you are in the third year already, so meron tayong Harrison's Principles of Internal Medicine textbook for our internal medicine subject. Okay? So yung lecture natin is not just purely physio. So meron tayong integration of our different subjects from physical diagnosis, general pathology, and then internal medicine, then physiology. So when we have patients with MSK pain, we ask them kung meron bang deep or diffuse pain, kung sakit ba jud kaayo or sakit siya kaayo pag ilihok, and pain on passive and active movement, no? Sakit siya gihapon dok maski wala ako naglihok, maski nakalingkod lang sakit siya, or musamot siya sakit dok pag itaas na akong tiil or lihok na akong neck or lihok na akong shoulder. So if the answer is yes, so let's go first with the for those responses with yes. Okay? So for example, mga na patient, yes dok, sakit yung kayo dok pag maglihok ko maski nakahigda or nakatulog, mukawon gyud mo sa sakit. So yes, no? Check yes. So follow lang ha, para di kayo mawala. So itong yes. And then next question, sakit gyapon siya ma'am pag mata mo sa buntag or maskin pag nagpahulay ka? Yes, dok, sakit kaayo. Unsa siya kasakit na maabot siya mga at least more than 30 minutes? Yes, dok. Malampas siya mga mabot siya mga isa ka oras. Ma-relieve ra siya ma'am kung magpahulay ka. Yes, dok. Ma-relieve lang siya. So let's go to the yes. Yes muna, no? And then pag yes dito, then next question in your mind, if kayo yung nag-atubang ani na patient, pila ka joints ang affected ma'am, no? Asa dapit ipatulo ninyo or just try to document kung ilang joints yung affected. Kung more than 5, that is already polyarthritis. Pag 2 to 4 joints, oligoarthritis. And then monoarthritis, only one joint. And then for that for those responses, meron siyang particular disease entity that is subjective or suggestive of ano yung mga medical conditions pertaining to that response, no? If the patient involved na yung more than 5 joints polyarthritis, think of rheumatoid arthritis, rheumatic fever, viral arthritis, or arthritis of connective tissue diseases. If the patient is complaining of about 2 to 4 joints, more than one, but less than five, and then insidious onset meaning chronic, no? Mawala, mabalik, and then usay okay, usay mawala, usay masakit, usay mawala. So insidious onset ang tawag namin dyan. So think of osteoarthritis, early rheumatoid arthritis, or spondyloarthritis. And then monoarthritis if only one joint is affected, and it can also be sudden, meaning acute, or insidious or chronic. So for the sudden onset, think of gouty arthritis or any cause of acute bacterial arthritis. Okay. And if ever, balik tayo dito sa level na dito, sa second level, if ever no yung response naman niya, then you further ask them kung apil ba ma'am imong hips, imong tuhod, imong kamot, then check for the hands of meron bang mga nodes. Pag yes, definitely the patient is suffering from osteoarthritis. If no, you have to consider other diagnosis. So that is from the algorithm na may yes. But paano naman dok pag no siya? Dito pa lang. So kung pain on passive and active, pain lang siya sa active. So dapat kasi pain on both passive and active. What if dok sakit lang siya pag ilihok? Okay? So meron kasing pain na on active lang, di ba? Pag i-move lang. So ganun yung patient natin. Sakit siya pag ilihok lang yung liog. So yung mga other diagnosis natin dito na na-highlight, yung sa baba, mm, yung dito sa ito na box, ito, and dito, pati ito. So na-rule out na natin yan kasi patient already, the three patients are complaining only of pain on active movement. So nasa no sila, no? And pag no siya, yung possible impression natin is patient is suffering from non-articular pain or soft tissue rheumatism. So, ito lang medyo ano lang natin, no? Gi, Isa-isa lang. So, yung gout, of course, our typical or pathognomonic findings for patients with gout is the podagra or the swelling of your first metatarsophalangeal joint or big foot. So that is pathognomonic for gouty arthritis. For acute bacterial arthritis is monoarthritis with patients complaining of swelling, redness, tenderness, and hot swollen joints. Okay, you can see this typically among patients with bacterial arthritis. So when you try to look redness, try to palpate, so mayroong warm, and they are acute in onset and painful. So patients with osteoarthritis, the typical picture of their X-ray findings, especially among long-standing na OA, is the joint space narrowing. So we have a radiographic classification grading system, grade 1, 2, 3, 4. Pag grade 4 na, meron ng severe joint space narrowing, such as what we can see here in the picture. And these are, ano to, what do you think ito na disease entity? So these are common findings for patients with rheumatoid arthritis. We have the ulnar drift, the boutonniere deformity, the swan neck deformity. Swan necks are same with the swan, no? Yung swan animal. We have rheumatoid nodule, yung na mga bukol-bukol, burot-burot, hallux, valgus, and bunion, common sa mga patients with RA, but can also be seen among patients with OA and the claw tooth. Yung ito. And then we also have a disease entity called the spondyloarthritis. So spondyloarthritis meaning na eggshell skeleton sa spine, no? Spine. And meron ding eggshell sa spine and hip arthritis. Pero meron din siyang peripheral spondyloarthritis, especially mga tendons and small joints, no? So ano pala yung spondyloarthritis, doc, naman disease condition? So when we see patients na merong psoriasis, then skin lesions with joint involvement, think of psoriatic arthritis, or meron ding patients na nagkaroon ng joint pain with gastrointestinal involvement. So think of inflammatory bowel disease-associated arthritis. And then patients na nagkaroon ng previous viral infection, think of reactive arthritis or undifferentiated spondyloarthritis if they met just uh, for example, meron siyang skin lesions and then arthritis, pero not categorized either as psoriatic or reactive. You can differentiate them as undifferentiated spondyloarthritis. Dun sa axial spondyloarthritis involving the spine and the hips, we have the ankylosing spondylitis, wherein we have radiographic finding of syndesmophytes and the bamboo spine. No? And then we have also have non-radiographic axial spondyloarthropathy patients complaining of back pain, but on the radiograph is wala pang makita. Common among patients with spondyloarthritis, yung uveitis, meron siyang eye involvement, eye redness and eye inflammation of the uvea. Then psoriasis on the skin, IBD, pag meron ng changes in the bowel habits, dactylitis, or what we call as the sausage finger, arthritis, especially on the knees, and then enthesitis, or the inflammation of the tendon, especially on your Achilles. So this is a patient with psoriasis and psoriatic arthritis, no? So we can see there, letter A, yung typical patient with psoriasis na hindi pa masyado lala, no? So parang may plaque psoriasis. And then sa letter B, mostly diffuse na, no? And then letter C, erythrodermic. Parang namumula na yung skin niya. Letter D, we have patients with scalp psoriasis dito. Dito, hanggang dito din sa likod, no? And then letter E, sa mga flexural sites like sa bilbil, sa liog, sa may kilikili, sa may siko. And then letter F, I think this is in inverse yata to sa may breast area. Letter G, parang mga postular. Letter H is mga nail changes, no? Yung letter I are yung mga deformities sa hands and the dactylitis as well as with the nail changes. Letter J, yung mga nail pittings. Letter K, mga, yun, nail, ano pa rin changes, no? Mga oil spots. So, my patients with skin, nails, and joint, think of a psoriatic patient, psoriatic arthritis patient. Ito naman is a patient with a classic triad of conjunctivitis, arthritis, and urethritis, common among patients with your reactive arthritis or writer's arthritis, no? Writer syndrome. So conjunctivitis, you can easily detect that when patients having red eyes. And then yung meron ding mga urethritis, balanitis, or circinata. Try to check the genitals, no? So patients meron ding mga genital lesions or mga discharges na common yan sa mga promiscuous na mga patients, mga men patients with gonococcal arthritis. So they have promiscuous, meaning dakan silang sexual partners, and then goes to your clinic, sakit ang tuhod. But upon history taking, noted na namumula ang mata, and then they will tell you na, "Dok, na ay nagatulo sa kuang gland, no? Organ." And then think of this condition, yung reactive or writer syndrome. Tapos, yun, meron din tayong tinatawag na keratoderma blenurgica. May mga keratoderma and or group pustules on plantar surface of foot. So, titignan mo yung hands nila and sa feet, no? Merong may mga lesions, skin lesions. Then, meron tendinitis like this one in the Achilles tendon as well as joint in the hips. And try to check then the oral lesion. Meron ding makita na mga swelling. Then one of the criteria for patients with Jones criteria for rheumatic fever, patients complaining of joint pains, para meron siyang mga other symptoms like cardiac involvement naman, no? So medyo severe naman ito, which is not we are entertaining for this patient. So meron tayong mm, at Jones criteria for rheumatic fever, at least two major or one major criteria and two minor must be present for us to diagnose rheumatic fever. So ano yung mga major criteria? So meron tayong carditis, polyarthritis, Sydenham chorea, subcutaneous nodules, and erythema marginatum. And then for the minor criteria, fever, arthralgia, prolonged PR interval on the ECG, increased acute phase reactant ESR and CRP, and leukocytosis. So this criteria or this kind subset of patients, you will suspect if merong patients na coming to your clinic na joint pains, fever, rashes, no? So think, and then cardiac involvement, think of aromatic fever. And of course, our prototypical autoimmune condition, the systemic lupus erythematosus, patients complaining of still of joint pains with multi-organ involvement. So meron siyang hair loss, headache, oral ulcers, muscle pain, cardiac involvement, may anemia, thrombocytopenia, then fingers having radiant phenomenon, and then brain, the butterfly rash, the lungs, water, no, may pleural effusion, then my hematuria, severe pain, and arthritis. So these symptoms can be present in just one set, in one can be present in in one admission or pwede siya as cumulative, no? So mean to say, pwede niya itong maranasan when the patient is still in the, for example, 10 years old pa yung patient. So meron na siyang nag-complain siya ng butterfly rash. So valid pa rin siya na symptoms. And then when patient turns 25, nagkaroon siya ng mga hair loss. So counted na yun siya na symptoms. And then pag 30 years old yung patient, nagkaroon siya ng thrombocytopenia and hematology condition. So, and then positive siya sa ANA and then the anti-DSNA, which is specific and sensitive for SLE. And that's the time that we diagnose these patients already. So for the hand OA naman, meron tayong tinatawag na Heberden's node and Bouchard's nodes. Okay? So sa Heberden's nodes, try to look at your hands. Kung meron tayong sa distal part, so dito banda, so distal part, think of Heberden's or heaven, no? Kasi distal man siya, so heaven, so mas layo man. Bouchard, more on the proximal, dito. Para hindi kayo mawala. It's just a mnemonic lang naman. So patients with OA, pass or other patients with kung negative siya sa rheumatoid factor, OA siya. Pag positive naman sa rheumatoid factor, and then other patients with rheumatoid factor will also have the Heberden's and the Butcher's node. Since we're left with the diagnosis of non-articular pain or soft tissue rheumatism, so we will go again, we'll go back to our patients, no? Yung first three cases natin, complaining of neck pain, shoulder pain, and back pain. So ano pala yung soft tissue rheumatism and non-articular disorders? So these are disorders that is from the word articular. So from the word articular is joints, right? So these are non-articular disorders. So these are disorders that are not pertaining to the joints per se, but for the soft tissues that is surrounding the joint, no? Like we have the periarticular tissues, the muscles, the tendon, the ligament, the fascia, aponeurosis, the retinaculum, the bursa, and the subcutaneous tissue. Those are the different parts that surrounds the joints. So, and pertains to the non-articular structures. And if ever patients complaining of that pain, definitely they are having a soft tissue rheumatism or non-articular disorder. So like this for this image, we have the articular structures involving the bone, the synovial membrane, and then synovial fluid, yung nasa loob na fluid, the articular cartilage, the intra-articular ligament. Okay. Comparing to our non-articular structures of our knee, like the tendon that connects the bone to the muscle, the bursa, small fluid sacs that reduce the friction, the muscles, the ligaments. Okay? So yan yung difference nila. That's why kung merong articular structures, the pain is usually present on active and passive motion. Whereas kung non-articular structures from the soft tissue rheumatisms, the pain is characterized as focal point tenderness, pain primarily with active motion lang siya. To differentiate the two, the articular deep pain, restricted motion, versus non-articular, there is already point tenderness and specific movements only. Okay. But in the soft tissue rheumatism na articular disorder, meron pa rin siyang, dami pa rin siyang mga different pa rin yung areas na involved, no? So if ever dun sa shoulder area or patient sa number 2 patient natin, no? So we possibly think of an adhesive capsulitis or bicipital tendinitis. Or if the patient's complaining of pain dito sa may sternal area, think of costochondritis or the Tietze syndrome. If the patient's complaining of pain here in the wrist area, think of decurvin stenosynovitis. Patient complaining of the pain in the lateral elbow, di ba? Think of lateral epicondylitis or the tennis elbow, di ba? Pag nagka-tennis. And then if the patient is complaining of pain in the medial epicondyle area, think of medial epicondylitis of the Goldberg's elbow. Then sa knee naman, no? So we have areas dyan kung masakit, like sa medial aspect. So, dok, sakit akong sa may tuhod banda sa tunga. So, think of anserine bursitis or when the patient complaining of dito sa may taas ng patella, think of suprapatellar bursitis, prepatellar bursitis, or infrapatellar bursitis depending on the location. At the back, like for the number three patient natin complaining of, sorry, la low back pain, and then dun sa number two, yung sa upper neck or shoulder area, think of myofascial pain syndrome, as well as yung rotator cuff tendinitis and adhesive capsulitis kung sa may shoulder area. And then yung kung sa likod naman, no, nandito banda. So sa likod, think of an olecranon bursitis. Tapos yung piriformis syndrome, think of that when the patient's complaining of pain sa may gluteal area, as well as ischiogluteal bursitis, yung sa may tender point, sa may sacrum or sa may puwet. Flexor tenosynovitis sa trigger finger sa hands natin, and trochanteric bursitis sa may hita. And then think of popliteal cyst or Baker's cyst if the patient is complaining on pain in the popliteal area. And yung mga patients na may ankylosing, may axial spondyloarthropathy, think of an Achilles tendinitis when they are having pain sa may Achilles area, and plantar fasciitis when they are complaining of pain sa plantar area. Or patients complaining of maglisod o lakaw kay sakit ang lapalapa. So think of plantar fasciitis. Now, let's go back to our case because kailangan natin balikan yung patients natin. For our first patient, a 35-year-old female office worker with neck pain, what is your impression? Say, think of the possible diagnosis. Healthy back. Okay. Okay, do you have your diagnosis already? Let's call Rosette Dinalo. Hello, good morning. Uh-oh. Hello. Yes. So I think may nag-raise ng hand. Si Erica Jean Gumilan.
Pwede po mag-try daw.
Yes, try to answer.
Okay po. Myofascial fasciitis po, Doc, or myofascial pain syndrome.
For our first patient.
Not, sorry po, Doc. I think sa second patient po, Doc. Sorry,
Uh,
Doc.
so for our first patient, sige. So let me answer na lang, no? So this patient definitely has an articular disorder kasi soft tissue rheumatism man tayo lahat, di ba? So non-articular disorder, a soft tissue rheumatism, but the patient is suffering from TEC or text neck syndrome. Okay? So that's not, uh, although wala siya sa yung picture or illustration na pinakita ko because this is entity. So TEX or tech neck syndrome or smartphone slump disease is a repetitive stress injury caused by prolonged forward head posture while using smartphones, tablets, or other electronic devices. and is linked to excessive screen time, particularly with handheld devices. So mostly guilty, no? Guilty tayo lahat dito, especially those nung naka-virtual class or naka-online class lang, like sa ginagawa natin ngayon, or those na sa office work. That is why I'm like yung sa laptop natin, no, dapat naka-eye level. So ganun, ideally, no, naka-eye level like that, no. So so that kung mag-lecture, naka-level lang sa ating mata, no. So differential na try ko gawin. Although walang patungan. So dapat ganun daw. Okay. Para dili magdoko. So when there is a repetitive injury, so that's the problem now in the modern world, no? Sa era na ngayon, because na digital era na tayo ngayon. Very rampant yung virtual classes, online class, Zoom lectures, pati meeting. There is an increased load on cervical spine dito banda. The average human head weighs only 10 to 12 pounds or mga 5 kilos. Forward head posture increases the effective weight. So kung the more, for example, dapat naka-neutral position na 0 degrees lang, so mga nasa 11 pounds yan siya or mga 5 kilos for a little bit, 15 degrees. So nasa 27 pounds na siya. So nag-double. All the more ka mag 30 degrees na 40 pounds na or mga 20 kilos and 60 degrees na sumunod na dako. So that's already 30 kilos na, 60 pounds because of the force from the gravity of the earth. Excessive use of mobile device pag more than 4 hours per day with poor ergonomics, magsilang duko, slouch position, couch potato, lack of regular movement and stretching that would lead to weak neck and upper back muscles. So for our second patient, a 42-year-old female housewife with shoulder pain. What is our diagnosis? So I think the answer ni Erica kanina. So that is non-articular disorder, a soft tissue rheumatism, and a myofascial pain syndrome. So what is myofascial pain syndrome? Comes from the word myo, muscle, and fascial, connective tissue. It originates in the muscles but may spread to the connective tissue or other areas of the body. Myofascial syndrome develop trigger points in muscle that feel similar to cramps. So when you try to have a patient with myofascial pain syndrome, then try to palpate, di ba kailangan natin siyang ipa, ipa-point ng part ng sakit. So when you try to palpate here sa my back area, so meron kayong manotice na palpable nodule or thought band. So mo na ginaingon sa uban na mga masahista or mga masseur na ay mga kanang panuhot, no? Murag daghan kag panuhot diri sir sa imong likod kanay mga hangin-hangin. So actually kung isipan nato scientifically, those are palpable nodules or the tote band na mga part ng mga muscle no nag-inflame. So dili na siguro na ma-classified, they cannot classify that medically, but as a physician we can have the impression of a myofascial pain syndrome if ever we can palpate or we can feel na meron parang mga bands dito no sa may shoulder area. This is caused by overuse or repetitive movements from the injury, from poor posture, from stress, from sleep issues, from sedentary lifestyle, and from nutritional deficiencies. So for our second patient, this is a housewife cleaning the house. So meron siyang overuse or repetitive movement no, from carrying heavy objects. For our third case, a 28-year-old female nurse with low back pain. What is your impression? That's called Carlos Jose.
Hi, good morning po, Doc.
Good morning.
Hi, actually, Doc, I'm not sure pa po sa impression ko po, but upon looking at the one po, parang upon looking at the upon reading the upon looking at the given case po, yung working impression ko po, basically, meron siyang acute mechanical low back injury po. Yun lang po. Pero most likely, parang on the specifically sa may lumbar para spinal muscle strain po.
Okay.
Yan.
Actually, you're correct. No, you're there already. So this patient is suffering from a non-articular disorder, soft tissue rheumatism, the non-specific mechanical low back pain. So I'm glad that you mentioned the word mechanical low back pain. So meron ng ano siya, meron ka ng advanced reading pala no sa low back pain. So the non-specific low back pain or mechanical low back pain, or they call it NSLBP, has the highest prevalence globally among the MSK conditions and is the leading cause of disability worldwide. Um, Try to think of the number one cause of disability worldwide still from the World Health Organization is the low back pain. So kahit low back pain na siya, murag very benign looking, di ba, no? So murag low back pain lang man na, sakit lang man na sa likod, but it's the number one leading cause of disability worldwide. The most common presentation of LVP is the non-specific or mechanical. And the risk factors include low physical activity, smoking, obesity, high physical stress at work, especially from our third patients complaining of, di ba, IC nurse man siya, so meron siyang high physical stress at the workplace. So to further classify a low back pain, we have the non-specific and the specific. So for the low back pain, we can further classify that as to the chronicity, like we have acute pag less than 6 weeks, subacute pag 6 to 12 weeks, and then the chronic pag more than 12 weeks. And then merong persistent and recurrent. But when we talk about the non-specific and specific, we have to first lay the foundation of from the root word, no specific. So because we are diagnosing this patient as non-specific, so meron ding term na specific. So specific from the word specific, or mas sakto siya kung unsa man yun ang cause, meaning ma if ma distinguish mo or ma-pinpoint mo ano yung cause, because yung specific low back pain pertains to back pain na merong etiology, no? Like serious spinal disease, wherein mga less than 1% lang of cases in the primary care yung vertebral fracture, metastatic disease, spinal infection, axial spondyloarthritis, or the Cauda-Equina syndrome. But meron ding mga radicular pain or neurogenic claudication, like mga numbness, about 5 to 10%, mga from radicular pain, radiculopathy, or spinal stenosis. Yung non-specific low back pain is more common because 90 to 95% of cases in the primary care, wherein it is characterized by acute non-specific low back pain and persistent non-specific low back pain. So try to think of the muscle. I hope na discussion na to, no, sa anatomy. Yung muscles involved in the back pain. We have the iliacus muscle, the psoas muscle, the gluteus sa may lubot, piriformis sa may lubot banda, the multifidus sa may spine, lumbar spine, quadratus lumborum sa may lumbar area, then the rector spinae sa may spinal area. So these are the deep and the superficial muscles of the back that can be primarily involved among patients complaining of a non-specific low back pain. So going back to our third case, this is an ICU nurse carrying heavy patient. So definitely there is a strain at the low back area, specifically the low back muscles. From the World Health Organization, the Global Burden of Disease report, yung meron tayong GBD, no? So it's still the number one cause of disability worldwide, aside from the cardiovascular diseases na siya yung leading cause of morbidity. Sa leading cause of disability is the low back pain pa rin, okay? So wag mong liitin yung low back pain kasi number one cause of disability. So meaning to say, this has a great impact on society and system, because a disability can have an impact on the economic loss, especially among the workforce, or those who are yung reproductive age group na working class. Okay, it can lead to cause of the absenteeism, premature work exit, and yung problem that is that kung more patients or more mga workers are absent, then tendency they can have no work, they can have no job, they can have no money to feed their families, and they will need rehabilitation medicine, will need medicines for the back pain. So kaya nagiging top one leading cause of disability siya. Kasi parang ah, parang na-disable, no? Disable yung patient from doing activities of daily living. So pathophysiology of muscles pain and spasm. So we have discussed from the neuromuscular physiology, di ba? Kung merong trigger. So kung merong trigger, for example, try to relate that to our three patients. So meron silang pain. So there's pain, there is inflammation from the repetitive movement, di ba? So, pag merong motion, so try to kuanda yung sa number one, ha. So, there is a muscle or micro tears or tissue inflammation that can trigger the local injury. So, the release of yung mga pro-inflammatory cytokines and the muscles for inflammation, and it will trigger your pain receptors, no? Yung mga C fibers, alpha delta fibers that will send signals, so your afferent signals to your nociceptor activation and pain transmission to the spinal cord. And then it's a multi-level kasi, no? From the site of injury to the spinal cord, the brainstem, medulla to the cerebellum, to the cerebrum, and goes back to the site of injury. Then after that, yung process is from afferent signal goes to the spinal reflex, goes to the motor neuron, and it activates your alpha motor neuron firing signal to the area of the muscle. That's why kung continuous yung inflammation and injury, continuous din yung pag-contract ng muscle. That's why once there's inflammation and pain, there's also spasm always, no? Yung sa muscle pain, so we have discussed on the pain pathways. So meron tayong mga triggers, the release of your substance P, mga prostaglandin, yung histamine that will activate the pain receptors. Okay? And then ito naman is aside from the pain receptors, magkaroon siya ng mga metabolic factors that will also sensitize your nociceptor signals and will lead to chronic muscle tension and high mechanical load and fibrosis increase in the pain sensitivity. Okay. That's why when we manage these patients, we must also understand the pathophysiology of muscle pain and spasm. Because when we manage these patients, we will be giving them the NSAIDs. So we must know kung ano yung work or mechanism of action of your NSAIDs, as well as the mechanism of action of your skeletal muscle relaxants and opioids. Historically, these are the medications that is parang binibigay natin sa mga patients na ganito. But we'll try to look at the comparison of the treatment options. Like, for example, for the muscle relaxants, ano ba yung ano niya, no? Primary action. It just calms the nerve signals into the brain or spinal cord to reduce the muscle tension. And it's best for short-term relief of severe muscle spasm, neck, back strain. And it has a direct effect on the pain cycle. How how about the NSAIDs, no? NSAIDs like your celecoxib, toricoxib, your mefenamic acid, alaxan, ibuprofen, no? So it primarily acts to reduce inflammation by blocking the prostaglandin production. And then it's best for acute inflammation and general musculoskeletal pain, but it has a direct effect on the muscle spasm control. How about the opioids? So you have the morphine, the tramadol, mga analgesics, no? So it just targets the brain's receptors to suppress pain perception, especially for severe air factory chronic pain, but it does not have a direct control of the spasm. So in short, if we are entertaining a patient with muscle pain and spasm, so ano yung best treatment option that we can give them? So we can give your muscle relaxant, no? Or we can give your NSAID, but it has not a direct effect on the spasm. So we can also give NSAID plus the muscle relaxants also. For the muscle relaxant, we can typically give that to short term only. That's 2 to 3 weeks. NSAID, short term lang kasi diba of the gastrointestinal, the cardiovascular toxicity. Opioid, we have to give them just not in a chronic use because of the addiction and tawag nito, kanang dependence, no? And the common side effect of our muscle relaxants, you have to communicate that to your patient na, Sir, ma'am, try ka na mura kag katulugon, mauga imong mouth, or sometimes wala kag malipong. Sa NSAID, kung mag-action hapdos imong tiyan, or magsakit imong dughan, tapos you have to be watchful for patients na merong mga elevated creatinine because of renal toxicity. Yung sa opioids, pag binibigyan mo ng tramadol, try to tell them na short term lang ni gamita or as needed lang always kay may risk na ma-addict ka ani na tambal, and pag high dose magkaroon ng mga respiratory depression magsunod ka ginhawa. So yung lecture natin to, so meron tayong aside from na-discuss natin yung physio, somehow sa physio, then pathology. And then we discussed the physical diagnosis, the internal medicine, we discussed the pharmacology. So, na dito lahat, no, yung topics na parang na incorporate natin lahat. And then, so classification of skeletal muscle relaxants, we have the antispasmodic and the antispastic agents. Okay? So, ano yung mga common antispasmodic agents that are available? But these are not yung sa Philippine market, yung meron tayong oral antispasmodic agent, yung orphenadrine. Okay? We have also tizanidine in our market, and we have baclofen as antispastic agent na available sa Philippines. So other medicines, wala siyang oral tablet form, only vial form or IV lang. Okay. So, ano ba yung mode of action of your anticholinergic drugs? So, meron tayong, remember yung sa neuromuscular junction, di ba? We have, I hope you already read that. Yung, we have the nerve, and we have the muscle, okay? Di ba? Or smooth muscle, skeletal muscle. So parang yung junction or yung parang border boundary nila is that ma-release yung acetylcholine. So let's try to look, ha. Just follow through na lang. So we have the normal cholinergic signaling. So yung acetylcholine from ACH binds to your M3 receptor. So it will increase the intracellular calcium. As we all know, calcium is really needed by our smooth and skeletal muscle to contract, di ba? So yan yung parang kailangan niyang substance or kanang uh, um, mineral or there's ion, no? Substance or molecule para mag-contract ang muscle. And it's also needed for the glandular secretion, like for example, ito sa number 3. So mag-secrete yung sa lungs, sa eyes, sa heart. And then yung action naman, yung anticholinergic drug is to block your acetylcholine at the muscarinic receptors. So meron yung Mark X, okay? So merong Mark X. So hindi mag-bind yung acetylcholine kasi naunahan siya ng drug like our anti-spasmodic agents yung orphenadrine. So maunahan niya, hindi makapasok ang acetylcholine. Pag mag-block niya, so hindi na makakaroon ng contraction because yung calcium yung acetylcholine hindi na makapasok doon sa membrane, di ba? So think of our topic naman on the cellular physiology, cellular membrane physiology. So yung anticholinergic drug reaction, so as a result, magkaroon ng decrease na bronchodilation. So yung kabaliktaran ng cholinergic is bronchoconstriction. So anticholinergic is decrease ang bronchodilation. So, yun siya, no? So, kung ma-block yung acetylcholine, ito yung mga cellular physiologic effect. So, sa secretion, mag-decrease ang secretion. That's why yung one of the um, side effect is the dry mouth, no? Kasi mag-decrease yung secretion sa salivary glands. And then, yung sa mydriasis, meaning mag-dilate ang pupils, no? Sa heart rate naman, mild tachycardia. ang reaction niya. Okay? As well as decrease ang salivary constriction, salivary glandular constriction. So ano ba yung other um, anticholinergic effect that you can think of? So pag cholinergic, think of the flight, the fight and the flight response stress, right? So dito, ito lang advanced lang. So although we will not be discussing naman yung gamot mismo, no? So yung studies on the orphanadrine as one of the muscle relaxant and placebo versus placebo or other drugs in patients with pain. So ano yung mga nagawa na ba ng studies? Kasi kailangan natin na we have, di ba, we have discussed yung mga levels of study designs like yung ano yung mga RCT, mga case control, cohort. So yun naman, importante yan siya for researchers na magkaroon ng evidence so that we can create or we can publish CPG, right? Yung pinaka-top sa pyramid natin. So, yung mga researchers, yung mga different studies, observational studies, mga case control RCT, kailangan talaga siya, no? As tool for us to get a high level of evidence if we will really um, give recommendation of giving this drug. For example, dito sa orphanadrine, focusing on orphanadrine, this was widely studied, no, as early as 1991 because this is an old drug already in the market. So acute shoulder, neck, back pain involves, yung naka-highlight yan yung may superiority of your orphanadrine against patient with acute back pain or neck pain, with musculoskeletal spasm, and with chronic pain. It's also studied among patients with chronic pain, lumbar strain, and low back strain, as well as patients having oral surgery. Okay? So there is a systematic review with network meta-analysis on the effectiveness of treatments for acute and subacute mechanical non-specific low back pain. So in making CPG, so we also need a systematic review and network meta-analysis, yung SRMA natin, no? So this study assessed the effectiveness of interventions for acute and non-subacute non-specific low back pain based on pain and disability outcomes. The design is a systematic review of the literature with network meta-analysis, and yung references niya or sources from the Medline, Embase, and Central databases were searched from inception until October 17, 2020. So this is one of the studies na nakita ko from PubMed, yung pinaka-latest lang, no, na systematic review and meta-analysis of your muscle relaxants and management for your low back pain, which involves RCTs among patients with low back and non-specific low back pain who experience pain for less than 6 weeks. So acute siya. Ano nga yung acute? Less than 6 weeks, and chronic pag more than 12 weeks or between 6 and 12 weeks. So from acute and subacute low back pain lang ito. So from the meta-analysis, included studies were 46 RCTs. So yung pinakita ko kanina, yung from 1991, I think na-involve na siya dito, no? And then involving 8,765 patients. So for the results, no? Let's go to the results. Most efficacious treatment for pain decrease against placebo. So exercise is also effective. Heat wrap, opioids, manual therapy, the NSAIDs, and muscle relaxant. So um meron pa rin talagang effect din yung muscle relaxants, NSAIDs, and the rest, no? And then mild to moderate adverse events from your mostly from opioids, no? 65.7% NSAIDs and from your steroids. And from based on the conclusion that among pharmacological intervention, NSAIDs and muscle relaxants appear to offer the best harm-benefit balance. So look at yung SMD is the standard mean difference kung ano yung mga pag-decrease ng pain. Okay? So sa NSAID and muscle relaxant, mga nasa 0.24 to 0.53, no? Negative 0.50 to negative 0.24 yung pag-decrease ng pain. And then because of the conclusion from this meta-analysis, so yan na yung ginawa. So, di ba? Remember from our lecture on our level of study design from different study. Wait lang, charge ko muna. Okay, so charging. Di ba, remember from our lecture? So, di lang that's not just purely lecture lang, but meron na tayong appreciate na application of that lecture from our research, di ba? From your meta-analysis, then nagkaroon na siya ng CPG. So kaya nga important yung mga meta-analysis because that's the basis for mga different societies of giving their CPGs. Like for example, from the American College of Physicians, in their publication in 2017, the Non-Invasive Treatment for Acute, Subacute, and Chronic Low Back Pain, a Clinical Practice Guideline in 2017, recommends that if pharmacologic treatment is desired, clinicians and patients should select NSAID or skeletal muscle relaxant, no, moderate quality evidence with a strong recommendation. From the American Academy of Family Physicians, they recommend the use of muscle relaxants are effective adjunctive medications for acute low back pain and neck pain with a grade B recommendation. And from the Malaysian Society Association for the Study of Pain, they recommend muscle relaxants may be added for short periods of time, usually less than 1 week, for the treatment of pain, especially if there's severe muscle spasm involved. So ito, wala na to, no? Okay. So that's the pharmacologic intervention. Now let's proceed to the strategies for the non-pharmacologic intervention. So we will advise patients to, especially kung sa first patient nato, no, we have to, because na tech neck or the slump syndrome. So meron tayong posture, advise them for proper posture, stretching, massage, movement, heat and cold therapy. Kung ma-refer natin yung patient sa rehabilitation medicine, may transcutaneous electrical nerve stimulation therapy. So meron siyang gadget, parang kinokuryente nila. So parang meron siyang electrical na stimulator. And then acupuncture, biofeedback, hydration, nutritional support because nga yung sa myofascial pain syndrome natin is mayroong nutritional deficiencies, especially calcium, then electrolytes, the sleep positioning, so proper sleep position and sleep hygiene as well as activity modification. So kung mag-sports ka, involved into sports or mas activities na strenuous, kailangan din mag-stretching, warming, and cool down. For the proper posture, so kung sa first patient, so dapat ergonomics pa rin the posture. Kung nag-cellphone, hindi magduko, no? Sa uban, mag-games lang, Mobile Legend, or mag-games, mag-Facebook, mag-post sa Instagram. So, sobrang kadako. So, pila to ka kilograms lang dapat? Mga nasa 5 kilos lang dapat yung neutral head position. So, every degree and angle, so mga times 2 times 3 ang weight. That's why nagkaroon ng neck stiffness. So correct posture when walking, correct posture when sitting in your computer or desk. Dapat eye level ang screen, and then yung elbow nyo dili pod nakaana, dapat ana lang pod no, neutral position gyapon. So correct position when lifting an object. And you can advise patient for home stretching exercises like ito naman is parang no-brainer naman to exercises. You can do that anywhere and anytime, like upper upper trap stretch in the neck, your levator scapular stretch, your deep anterior neck reflex stretch, your suboccipital stretch, and your rhomboid and middle trap stretch. No? So mga position or mga stretching na very practical and very it's not costly no? Kasi you can just do that. Then sa low back pain, so when you are in the supine position sa bed, pwede ka mag-knee to chest, cat-cow stretch, child's pose, pelvic tilts, seated twist, bridges, piriformis stretch, spinal twist, beard dog, and then can perform 2 to 3 sets of each exercise, diba? So, ano nito is when you wake up in the morning, you can do this, no? Before ka magtindog. You can single knee to chest, lumbar rotation, rotational stretch, and glute to bridge and push up. Okay, so for the last slide, complete history and proper physical examination can establish the clinical MSK diagnosis. So we have extensively discussed that, the steps and algorithm. MSK disorders, particularly low back pain, remains a top cause of morbidity worldwide, as evidenced by the Global Brain Disease and the WHO report. NSAIDs and muscle relaxants appear to offer the best harm to benefit balance based from the meta-analysis published in 2021. Pharmacologic multimodal approach with orphanogene citrate plus paracetamol combination is superior in alleviating pain muscle spasm versus other drug combination, and from diagnosis and intervention, both pharmacologic and non-pharmacologic leads to symptom relief and good quality of life. So do you have any question before I will give to you your task for this morning? Because your instruction for your group work, I know for your individual task, no? So this is an individual task. Open your cameras because I will be looking sa inyo, no? And then get a clean sheet of paper, yellow paper, bond paper, close all apps, programs, AR chat box, submit through Google link file, and time limit only 1 hour, no? So yung gawin nyo, make a concept map on skeletal muscle contraction, make a concept map on skeletal muscle relaxation, make a concept map on smooth muscle contraction, and make a concept map on smooth muscle relaxation. So this is already a long overdue quiz, no? Kasi last week walang lecture, then kahapon walang class. So a concept map is like this. You will, and this is an example of a pain pathway concept map. And then yung isa is for neuromuscular, muscle spasm, and contraction. So parang ganito yung gawin nyo, but you will do it on your own based on what you read and based on your understanding on the skeletal muscle contraction, no? And smooth muscle contraction and relaxation. Okay? Sige, so I want you to open your cameras. All of you, please open your cameras so I can see you. And then get a piece of paper. So ito naman, please make this naman with all honesty, no? So hindi naman ako I trust you while doing this assignment or doing this task, no? Based lang on your honesty. So I really value intellectual honesty. So kayo naman din yung magsasuffer if mag-open kayo ng laptop or mag-check kayo sa AI, ChatGPT, just to pass the quiz. Kasi yung importance nito, when you make a concept map as early as first year, you will fully understand the concept of skeletal muscle contraction, smooth muscle contraction and relaxation. And hindi na kayo ma hindi na mo makalimot, no? Once you will make a concept map, even mag-review na kayo for the board exam, magbalik gyapon mo sa concept map, no? ito pa rin yung kailangan yung i-memorize when you review for the board exam. So, yan yung lesson na gusto ko i-impart sa inyo because during my time, hindi ko nagawa na mag-make ng concept map. So that's why nung time ko na mag-take ng board exam and during the review, so dito pa ko nangapa no na magbuhat ng concept map. And then that's why kung meron kayong makita ng mga blog or mga sa balagi na ingon sa uban mga students na nag-review, nagabutang sila og concept maps, di ba? Sa CR, sa wall, sa ilahang room, sa bed. So, kana siya, medyo late na nila nagibuhat during the review na. So, ngayon, mas gusto ko ma-instill sa inyo as early as now, you will make this concept map so that based from this concept map, pabalik-balik na lang siya, di na mo mawala. Because when you go to the second year, third year, fourth year, and review the board exam until you become a doctor, paulit-ulit lang kasi ito na concept. Okay? So, are you ready now? Meron na kayong paper with you? So when you do this, since i-submit nyo to as Google file, no? So siguro pwede rin mapicturean, then i-attach lang sa Google file so that ma-check ko siya as a Google link lang. Pwede bond paper, pwede yellow paper, basta clean sheet of paper lang, no? Kuan lang class ko, kung sa lang jud inyong nasabtan, no? Dili man ko kailangan og kanang perfect gaya yung concept map. I just like to know the level of your learning and your comprehension based from your reading assignment since last week pa kasi ito, no? So I hope you read na because that's the instruction and you comprehend and analyze the lecture and how you apply, no? So this is a test of comprehension. Medicine is not a test of memorization. Medicine is a test of comprehension and how you understand the subject matter. So while doing this task, naka-open ang camera. So it's already 9:20. So by 10:30, no? Okay, you can proceed now.
Dok, pwede po pa ulit nung slides ng instructions.
So make a concept map on skeletal muscle contraction, skeletal muscle relaxation, smooth muscle contraction, and smooth muscle relaxation.
Doc, isang bond paper lang po yun lahat or different bond paper per
Pwede man different band paper para
So,
dili mo malimit sa space. So parang ganito, no? But if you would like merong mga color, you can do that, no? Hindi naman siya strict sa ano. Yung may mga highlight, pwede naman gawin. No?